Well, thank you for joining us for ACMHAI's webinar on the Winnebago County Criminal Justice Center. We're thrilled to have our two speakers here today, Sana Siddiqui and Sergeant Eileen Stewart. And I'm going to provide some background information, and then I'll turn it over to both of you. Sergeant Eileen Stewart has been with the Winnebago County since 2012 and took over oversight of the jail's mental health grant in 2024. She's been an advocate for mental health and mental health care for the clients within the jail, even before the implementation of the mental health grant funding. Sana is a mental health grant coordinator and has been with the Winnebago County since 2023. She's worked in crisis mental health from children through adults and has previous experience with substance use disorder clients. She's interested in justice-involved populations and focused on reducing recidivism through connections to support services for clients coming through the Winnebago County Jail. So thank you all for joining us, and I'll hand it over to you.
Well, thank you for having us. On behalf of Winnebago County, I want to say thank you for allowing us to be here and to share what we have and what we know. Of course, a huge thank you goes to the Winnebago County Community Mental Health Board with the half-cent sales tax in Winnebago County. That's what supports us, what allows us to do what we do. So our behavioral health unit in the Winnebago County Jail, we have two separate entities. We have a medical unit, which is contracted through UIC, University of Illinois College of Medicine. They fully staff that end of it. We have a mental health unit, which is facilitated. Our behavioral health program is contracted through ACH, which is Advanced Correctional Health Care. A subsidiary of that is Freedom Behavioral Health. That is who we have as our mental health providers in the jail. With the wonderful grant we have received, we are able to fund that program, and we have Pearl, who is our nurse practitioner, our psychiatric nurse practitioner. He's full-time on staff. He's 4 days here, 1 day's remote. And we have another nurse practitioner, Jen. She's here on Wednesdays. She fills in part-time on the day he's not here. We have 3 qualified mental health professionals here full-time throughout the week. Their hours vary so that we can cover Monday through Friday and then Saturdays and Sundays as well. We have Megan, who kind of heads that department, but she too is a qualified mental health professional who makes contact with the inmates. We have
discharge planner.
We have our discharge planner, Christy Wilson. We have Sana, who are all paid through that grant. The group of these men and women collaborate with UIC on the medical end, and maybe I'm biased, but what we do is phenomenal. Our outreach goes far beyond what the jail is. With our outreach programs, with our connectivity to our other resources, we're able to connect into a lot of the other programs that the Winnebago County Community Mental Health Board provides grant money to as well. So utilizing all of these resources for us it's just phenomenal. We've been able to go leaps and bounds and do things and begin things. One of our biggest and most proud achievements, I think, since receiving the monies is our medication assisted therapy, the MAT program. Some people refer to it as medicated assisted recovery. So we either refer to it as MAT or MAR. So throughout the program, if we refer to MAT or MAR, that's what we're speaking of. So for everybody coming in, there's a beginning assessment program. Medical will assess first. Mental health then assess each and every inmate. If they don't get a chance to meet with them directly at intake, they'll circle around and get them within the next 12 to 15 hours and touch base with them. Do you have anything else you want to add to that part?
Yeah, so during our medical screen, we do start by getting sort of their background history, just so we can make sure that we can provide a continuation of services when we have people coming in to our facility. We work with outside providers to make sure that we can continue them on their medications that they take out in the community. And we try to find out if they have any opioid use disorder, self-reported opioid use disorder. If they aren't necessarily able to report that during their medical screen, we do try to cover for any gaps. When they have their mental health screening, we make sure to cover that base of opioid use disorder as well, just to make sure that we can continue those services while they're here, or make sure that if we have to start some type of withdrawal protocol for them, we can do that in an efficient manner. We, in part of our in our mental health screening, we also sort of screen for any other diagnoses they may have, any community care that they have established, or if they're missing any community care, we get them connected with our discharge planning so that we can establish that care for them. Now those are for the people who are just coming into jail in their initial screenings, but we do offer additional services for people who are incarcerated here for a longer amount of time. Do you want to continue with when they're incarcerated here?
Well, and just to touch base, when at the intake process, when they state that they are either going to go through withdrawals, if they haven't been previously on the Mattermar program, we have not initiated another phase yet where we start, or where we will initiate Mattermar in the jail. If you come in having been already prescribed that program, we will continue it. If you haven't and you're going to go through withdrawal program, this is where our team really ups the ante, in my opinion. We have the cognitivity of care, the continuity of care, what they do together when they do get together, because medical will then have to begin the withdrawal protocol. After that, mental health has to continue to round on them. Mental health will then assess. It's typically a 5-day program for withdrawing protocol. If the inmate patient needs more than that, they collaborate, they get together, they'll discuss that. They may need to extend that a few days. But to have two separate entities, to me, I feel that brings two different ideas, two different sets of what you know and what I know together to the table so that we can better assist and assess.
So when we have someone who is incarcerated with us for a longer amount of time, some of the mental health services that we provide, they fall under the umbrella of our program, which is called the Behavioral Health Services Program Enhanced. So it does sort of add into some previous things that we did offer. In addition to that mental health intake screening, if someone reports that they're experiencing symptoms, emergent symptoms, something like anxiety or I think we get a lot of anxiety, but also,
The
suicidal behaviors or thoughts as well. They can report that in a kiosk that they have access to. Mental health is able to view all of these requests and needs, and they can respond to them by meeting with them in person and kind of helping them work through some of those symptoms. It's not quite the same as traditional therapy, only because they are with us for a shorter amount of time. Generally, we don't start that traditional therapy due to the risk of sort of opening up traumatic events that we won't be following up with them within the community. But we do offer some support for those emergent mental health symptoms. We provide observations for people who report suicidal status, people who are on withdrawal protocol. We round on clients who are in segregation just due to the risk of they face with their mental health kind of being segregated. And then we have a referral process where anyone who is reported to either show symptoms of concerning behavior or reports suicidal thoughts or ideations, they are met with a mental health professional. Is it the same day or next day usually?
As far as suicidal referrals, if we don't have a mental health clinician on staff from about 8 at night till 8 in the morning, they will hit them first thing, 8:15 in the morning. They try to get together with them they will get together with them prior to them going to court.
And that's when they conduct a risk screening on anyone who has been flagged by corrections officers or self-reported suicidal symptoms or, medical, basically anyone who interacts with that person. If they have that concern, they can put a referral for them to meet with the clinician. That clinician will meet with them. They do a crisis level assessment to sort of determine what their, level of need is at that time, and how we can ensure that we get them connected with that. Usually they're either cleared to sort of return to their normal housing unit, or they remain on observation status, or do we send people out?
We do. If they remain on observation status and they are released, we certainly just don't open the door and release them. We reevaluate what's going on. We speak with medical, we speak with mental health, we devise a plan. The plan of action would be if we have a parent who we know is fully on board with the inmate patient and a possible recovery process or a possible having received psychiatric help in the past for suicidal ideations, we will feel that through and discuss that with mental health. It's a possibility to release them to that parent, that family member, whomever is maybe in charge of this person in their progress. We will typically, though, we call what's form fighting them, and we will escort them with an officer escort to Swedish American Hospital into their psych unit. We would never, if we have fears, we could even override medical, we could override mental health, which we have in the past, thinking we're just not comfortable with this, opening the doors to these people. We think they need further assessments for the treatment.
So in addition to the observation and sort of follow-ups that we do for people who come in and are reporting mental health symptoms, another big service that we are able to provide here at the jail is discharge planning and community linkage services. Now we have multiple referral sources. One, we identify anyone who is arrested in the last 24 hours, and look for any risk factors or flags that they may need some additional support in the outside community. Now, whether that additional support is with mental health services, substance use services, or other community needs such as transportation, housing, personal effects, we screen for that through our arrest list. Another referral source that we get for discharge planning will be from our QMHP clinicians. They will meet with the clients, and during their intake screening, they ask, would you like to meet with a discharge planner? So we can receive referrals that way. And we can also receive referrals from people who are self-requesting those discharge planning services. So we really try our best to, make sure that anyone who could benefit from those services, that we're able to meet with them and provide those services. We usually try to meet them before they go to arraignment court in the afternoon. Since the implementation of the Illinois Safety Act, we do have a lot more people who are getting released from jail the same day. So we focus most on getting in touch with those people who we know are about to be released and who need that additional support out in the community. When we have people who are incarcerated for a little bit longer, we're able to get them started on things like housing programs or some other programs as well, so that we can get ahead of the game when we're anticipating a release for someone. But for those people coming in who are likely going to be leaving the next day, we do offer those referrals to any community mental health providers, substance use providers, medication providers as well, and other resources that they're looking for. We will screen them through what they need. And then another service that we offer for incarcerated individuals is getting them connected with additional court programs to sort of help them work through and resolve their cases. I have another slide later on where I'll get a little bit more in depth into that as well. And then in custody, these are a little bit more of those in custody services if you want to.
Well, we also have, each inmate in here receives a tablet. The tablet has things, it also incorporates their phone. They can make calls out, they can text out to family members and friends. The tablet also has consists of like a kiosk in of itself, where they can reach out to medical on their own, they can reach out to mental health on their own. If they don't feel comfortable approaching the officer, we have a great deal of officer assisting. If somebody just, so when we do our classification process, it's probably about a 15-20 minute period where you're just alone with an officer and we're going through a series of questions, and sometimes something does trigger something. Sometimes the inmate does start calming down and maybe will start opening up after having just been here for the first 24 hours on what could possibly be either the worst day of their life or a continuation of. We offer them services there. If there's any mental health concerns whatsoever during that process, the officer themselves will put out a quick report, notify their supervisor, and we call it a green sheet simply because the piece of paper is green. We call it a green sheet, which is a medical and or mental health referral form. And that gets typically seen within 10 to 12 hours. And we'll get the inmate into on what would be considered a non-emergent basis, but still to expedite it, knowing that they'll be possibly leaving us soon. I think one of the biggest pluses in this is when they first come to the window, if they're anxious or they're upset or they're forgetful and they don't think to tell medical everything, or they don't think to tell mental health everything at that first initial assessment, they've had an opportunity to maybe get a little bit of sleep under their belt, maybe either sober up or calm down or realize that they might be here for a little bit. And then they can talk to the officer, and we ask those same said questions all over again, which allows us yet a third opportunity to maybe again assess and assist, and they're really opened up about us because I think it's proven success time and time again that once we get them started on their meds, if they were on it before and they just stopped, or somebody stole your meds because you're homeless, or you've taken them all at one time, which was may have what wound you back up in here, we can get those meds started again for you. It takes time, and it doesn't take as much time as it would on the outside, but clearly getting somebody stabilized so that they can share with us more of maybe what's really going on instead of still being in a manic state, really, I think helps us move
Yeah.
forward and get a better idea of where this individual is in their own head, in their own body. And again, that's where we have to have the collaboration efforts with both medical, mental health, and the jail as well. Because somebody could be, like Sana stated, in max or seg based on their behavior. If they're argumentative, if they're aggressive, if they're a harm to themselves or others, it's not like being in general population where you have access to your tablet, where you have access to medical or mental health more easily. So that is when we then round on them through medical or mental health so that we can go to them rather than them not having an opportunity to come to us. There's still contact being made.
We have classes in the jail for people who are serving any time in custody. There's, NAAA, so people can kind of get started on that support program while they're here, like that peer support program while they're here. Goodwill does a class for us every Thursday. Here in the jail, they offer services such as sorry, let me take a look here. So they offer cognitive behavioral intervention services. They're able to start working with them on things like work readiness, interview preparation, some soft skills training. They help them get set up with jobs and job placement, GED or other continuing education, vocational things that they're looking at. And they can help get them those crucial documents that so many people who come into jail are missing, their IDs, their birth certificates. They help with getting, Medicaid and Medicare reinstated. Because
Social security cards.
Social security cards, yep, exactly. All of those documents that are such huge barriers to people going back out into the community and getting connected to any service. Goodwill is able to help get them started on that process while they're here, while they're incarcerated. And they hold that class every Thursday. And I think that they have a pretty good turnout. They can have people come in there for a couple of weeks to start working on all of those services. In addition to those classes, we have a chaplaincy service here within the jail as well. One thing that I've utilized our chaplain for, myself, is when we've had clients and we receive news that a family member on the outside has passed away, being able to utilize a chaplain to speak with them and to sort of guide them through that process can help people sort of stabilize in a moment where they're very vulnerable, you know, to having these suicidal ideations or to sort of spiraling in a way that could be pretty harmful for them. There are religious services, there are Islamic, even like prayer services and educational classes, and
Catholic service.
Catholic services as
Mhm.
well. Yep. And they offer all of that here in-house. We've had our chaplains work with people who are non-English speaking, who need some support services as well with their families outside of here. And I know that they have worked with families and incarcerated individuals who maybe need help with like DCFS, like mandated parenting classes. We've worked with the chaplain to sort of get some of that as well. So our chaplaincy services are like, they're fantastic. They sort of cover just a plethora of different things as well.
And our tablets that we were speaking of earlier, that the inmates have in their possession, if you're in general housing, they have these in their possessions. They can sign up for these classes. They can be a part of these classes. They
Yeah.
can be informed about these classes. There's also a little keeping your mind sharp type classes that the inmates can take on that, so there's not complete boredom. You know, they can have their tablet unless there's a disciplinary issue. They can have their tablet 24/7 once it's charged. The only time they would not be able to have it is disciplinary, or if it's on the charger, just recharging like a normal phone or a normal tablet would be. But the reach outs that they have on that, I think is wonderful. They can sign up for these classes. They can even take basic cooking classes, basic chef's classes, which I think makes them feel important. You know, they've been given a little certificate. You know, they did complete something that you would take, say, at Rock Valley Continuing Education. You know, they're not paying for this. It's something to call home about and brag about. You know, a lot of these people, once they're in here, they're worried about disappointing mom or dad or grandma or husband or wife or kids. So you hear them on the phones talking and you see their mail coming through. They're proud of these things. It gives them a sense of pride, saying, you know, well, I know I did this, but hey, while I was in here, this is what I've accomplished. So for them to feel even a little bit accomplished while sitting in jail, to us, I think that helps your mental well-being, as it would any of us, you know,
Yeah,
potentially. So
absolutely.
the tablets are a huge resource to us
Yeah.
and to them for their mental health outreach.
Yeah. Some other mental health services that we offer for people who are, again, serving some time, who are incarcerated with us for a while, is each of the qualified mental health professionals. We have 3 who, and plus their supervisor, but the 3 other qualified mental health professionals, they offer weekly or bi-weekly classes.
That's weekly, yeah.
That's weekly. Okay, weekly classes. Each clinician has a different class that they sort of own the curriculum for. We have a class called Thinking for Good, and that one addresses sort of criminogenic thought patterns, and you know, will help you kind of restructure your thinking. It asks some of those questions that maybe when people are on the outside, they don't necessarily have a lot of like insight into. So it does give people a lot of insight into some of their thinking patterns and how to restructure those. We have a co-occurring disorders class as well. Obviously there's so much overlap between substance use disorder and mental health diagnoses. So the co-occurring disorders class that we offer, it kind of helps, teach people sort of that overlap and how one can lead to the other, and how you can support both your substance use disorder and work on recovery, and how that can impact your mental health and vice versa. And then we have another class that's called New Directions. That's essentially a socialization class. I think all 3 classes, we get a lot of really great feedback from the inmates. They're able to share feedback and sort of their experiences on that. And we used to have a different set of classes, but we're constantly like having our qualified mental health professionals learn and get continuing education so they can continue to offer classes that are relevant and that are sort of well received by our inmates here.
Also paid through the Winnebago County Community Mental Health Board grant. It funds some of our clinicians' continuing educational needs, which, as we all know, with everything that's going on out there in the world, that changes on a daily basis,
Yeah.
let alone weekly, monthly, yearly. So if they've worked for this firm, this establishment for a little bit of time and haven't been re-educated, I think we're doing them a disservice, but we're mostly doing our our inmate patient
Yeah.
a disservice that we have to put back out into the community. So I feel real confident that our clinicians are being kept up on the most modern techniques, the most modern,
Like treatment modalities.
I would say
yeah.
treatment, but also what's going out there on in the world, since they kind of work in the jail. We're kind of an enclosed environment. We don't have a whole lot of outside forces
Right.
coming in. You don't have that connectivity talking to, you know, the person in the cubicle next to you
Mhm.
who's maybe been out in the community doing different things, or the community coming into you. Our clinicians are kind of kept, you know, behind the four walls and aren't out there in these group settings learning more and seeing more. So for us to be able to educate them and send them out or send them to classes or online classes for further education, and unfortunately what's new in the world coming in that a patient might be ingesting.
Yeah. In addition to that, one other big thing that we've been onboarding and we have a pretty good process for right now is doing in custody assessments. These are primarily for a substance use disorder or mental health. We partner with an agency out in the community. We're able to have these assessments done remotely, and we're working toward having these assessments done with an assessor in person, just for the added benefit of having that conversation face to face. So they screen for any mental health concerns that someone is reporting, any substance use concerns that a person is reporting, and then based on that assessment, they're able to give us a recommendation for the level of services that they need, whether that's inpatient treatment services, outpatient treatment services, intensive treatment services, or following up with something maybe a little bit less intensive. We get those referrals and those recommendations on the level of treatment. And of one other function that I do is I'm able to collaborate with the court systems on those treatment recommendations so that we can make sure that we're able to get anyone who is going through the justice system connected with that treatment that's going to help support them and maybe reduce their return to the justice system. Let me move on to the next slide here. That comes along with our discharge planning services, which I touched on a little bit earlier. These are just a couple of things that we're able to get them connected with. One big thing that we have been working on, and this is an issue in Winnebago County, as I'm sure it is elsewhere. We have just a lack of housing availability for people who need that housing service. But we are able to get people started on some of these lengthy housing processes while they're incarcerated with us. Our goal in doing that is obviously to reduce the amount of time that they're waiting, and to maybe get them started on some of that waiting process for housing. Sometimes it helps when we're collaborating with the courts as well, because without stable housing, people are often kept incarcerated longer than they would be if they had some sort of supportive or stable housing. So our ability to work with community providers to get that housing process going while they're here with us before a discharge date, before a court date, it really does have benefits. We had a really successful example several months back where someone who had gone off to a facility to be restored to fitness, returned to us while they were waiting for their next court date. We started the housing process for them. We were actually able to get them housed directly out of jail and get them into a housing apartment actually as soon as they were released from jail. And get them connected, you know, with their medication and kind of what else is needed. So that's sort of a process that we're still refining and kind of working on, because it's not always that streamlined, and it's not always the, maybe we were very fortunate in that case, but it's something that as we are able to, we definitely try to prioritize getting them connected with housing while they're here in the facility here with us.
We also have located inside the facility as our CCRT team, which was also funded by the Winnebago County Community Mental Health Board. And we have accessed them on a few occasions when we've had an inmate turn themselves in on a warrant, for instance, and then erratic behavior displays itself right at the front desk at the point of entry, you know, before they're technically our jail
Yeah.
inmate, we really can't do anything about it. So we're able to, I literally walked across the hall, made them aware. They were able to make contact with them, and we have 3 different policing agencies. We have Winnebago County, the city of Rockford, and Loves Park all in there. They also have Rosecrans in there. There's clinicians in there. They were able to get this person to a reasonable state enough in order to us not having to take them to the ground, us not having to put cuffs on them. We could physically walk them over into our jail because we were all on the same page and all kind of made aware of this at the same time. We were able to be ready in the jail. I was going to say, from a mental health perspective, if you had to make a video of how to do things exactly right, this would have been the perfect pristine example. Everybody's training kicked into gear, from the intake officer to the intake medical staff to the patrol officers at the front desk that walked them over to CCRT coming over to meet up with us, to a point to where it got to our mental health team. And this person, it was probably about an hour start to finish, but we got him dressed in, we got him into a cell, we got him behind a door. We never once had to use handcuffs. We never once had to use any type of physical restraint. This person was cooperative with us to a point where we even got the information out of the inmate that we needed. So it was, the proof was in the pudding on that one, in that these resources are paying off. We are being more educated. We are being able to understand our resources. A second element to all of that is, having received funds from the Winnebago County Community Mental Health Grant, we have mandatory meetings that we go there and have to meet up with them with. Well, we do that in a group setting where everybody that receives these fundings are part of that. So it's kind of an outreach there. You're meeting people, you're being made aware of some facilities or some services that you may not have even known existed. It might be something new to the community. Might be something that's been around for a long time, but maybe on a smaller basis, but with this new funding can expand itself. So we're finding maybe possibly more beds available.
Yeah.
Maybe more outreach services available to us, which we may not have known about. Again, we work in a confined setting in the jail where we don't get to go to these outside sources as much as maybe the normal recipient would. So to have those meetings and to have us gather together in one place and share our stories and share what we know and share our services and what we have and exchange the business cards, you're putting names with faces. And when you do that call, you're calling Susie instead of just that individual there who is in charge of this or that or the other. You're actually asking for a person who said, no, call me, here's my card, here's my extension. You call them directly. And I think that's been hugely helpful for us and for me in particular.
It's helped us sort of expand the services that our discharge planning will connect people to, just by going to these meetings and sort of collaborating with people in the community. We're able to get people connected to more and varied service providers, whether that's mental health or substance use. And I think it really has been helpful when we have clients here who maybe have special needs, who, for example, someone who might not be able to attend an in-office doctor's visit or psych visit is able to attend one through telehealth. And so just being exposed to those services, it's been really beneficial for us being able to get our clients here connected with the most appropriate service for them as well. We've already kind of talked about some of these other linkages that we do through discharge planning, so I'm not going to go into details on that one right now. But I did just want to touch base on when we have someone who is leaving, or even while they're incarcerated, we can refer them to a whole plethora of court services. And we have drug court, which is that supportive court service, so that someone who may have started some type of substance use treatment or services while they're here in jail, they could be a good referral to drug court. They get that pretty intensive support once they're released through the justice system that sort of helps them work through their charges, and that sort of helps them hopefully work on their substance use disorder as well. TIP court, that's a therapeutic intervention court. That is very similar to drug court, but instead of the substance side of it, it's working more with the mental health side. Veterans court, I glazed over this earlier, but we also have veterans affairs workers who are able to come into the jail and get started on a lot of the services that we talked about with the veteran population. They're able to come like same day or next day. So it's really wonderful being connected with the veterans as well. Veterans Court just helps those veteran populations work through their charges in a way that's sort of supportive to their unique needs as well. And then the wellness track, I'm actually really excited to talk about this one. It's a program that just got started maybe 3 years ago.
Relatively.
It's very recent. I believe roughly 3 years ago, and it was sort of born out of the court's noticing of this gap of supportive court services for people who had a mental health diagnosis, a significant mental health diagnosis that was maybe impacting their behavior to the point where they wound up in the justice system. So it does work with people who have misdemeanors and other low-level crimes. It doesn't really work with those violent offenses, and it doesn't cover the offenses that are covered in something like a DUI court or something like that. But it works with those people. It's sort of a triage type court where it gets people connected with the community-based services that are impacting their mental health, that once they start to work on that, the criminal behavior, the criminal charge is addressed and resolved. So we've had a lot of success with participants who are able to go, through the wellness track and who are able to resolve their cases in a way that gets them the support that they need. Going to these wellness track court dates myself, I'm really impressed. The judge will talk with you face to face. He'll kind of say, how are you doing? Have you made your appointments? I noticed you were having trouble with this. Like, how's your family? Have you moved? Like, it's very conversational. It's very empathetic. And it's something that us being able to refer people to who come into our jail, I'm super proud of the wellness track. I think that collaborating with the court in that way just kind of helps us provide the supportive services that people need from the time they come in. And it's not like it stops when they leave the jail. They continue it through the justice system so that they can continue to get that support they need.
And if you're having trouble getting to your appointments, and if you're having trouble getting or taking your meds, why? What is it that we have to do that we have to tell Sana, the jail, to get done before you walk out that door? And then our mental health staff rises to the occasion to that and finds the answers to those questions and finds a resolve for those questions. Obviously, it always comes down to the individual really wanting it or needing it, but when you're homeless and you have nowhere to go and you need to get in someplace, you're probably gonna sell your meds to get some money when it's gonna be 30 below wind chills at night. So I agree with Sana, the wellness track it's awesome. It tries to devise a plan before you even walk out the door, so there's no recidivism, literally sometimes that same day where you get rearrested to come back in where it's warm.
So that sort of, I think, covers our services from when someone comes into jail all the way, through the justice system. We do have some upcoming services, just to sort of round out that even more that I think I'm super excited to.
I'm really excited for, we're going to start a peer navigator program where, and to me, this is big for everybody, but I think women in particular oftentimes, and both men and women, but women in particular, once you're released from jail, typically you have your abuser, you have your pimp, you have your dealer literally waiting in the parking lot outside our doors for you. So the room we've established that we're going to build as a resource service center, instead of taking a left to go out a door that we have to unlock for you, you can take a right into an open door that's not locked, and you will receive services from our peer navigator. You will receive services from our discharge planner and any outside entity that wants to house in there for this time being, if they know you're being released from court, Rosecrans, so on and so forth. If you want to reside in there because you're aware of a bed possibly, these people, we will literally drive you to where you need to go to be safe, to get that next step and the next level of care that you need. You won't even have to go out that door. We will literally drive you to where you need to go to get that help, to get those services, to be safe, or to start being safe.
Yeah. And, we've definitely had people who have come through the system who are in situations where they may need to access something like a domestic violence shelter. So being able to have this resource center and these peer navigators as an option to stop at instead of heading out that door is one more point, right? Whether it's the entry referral, whether it's the behavioral health intake, whether it's discharge planning, whether it's in the court, here's one more point while we still have someone in our facility before they walk out, just to try to make sure that we can provide any of those like crucial services that maybe, for whatever reason, they have not been comfortable accessing while we had them up until that point. So that's in development. That's something that we're looking forward to.
Does anybody have any questions for us or any input or any suggestions? It doesn't have to be questions. It can be suggestions. If you have an idea, you've heard of something that maybe we can implement into any of these phases of what we already do.
Hi,
Hi.
I'm Jody Gardner. I'm from St. Clair County, Illinois, which is the Belleville area. I actually have a question about the technology, but I don't want that to detract from my admiration and amazement about your personal contact from start to finish. I don't even know what to say about all of that. The discharge planning and that resource room is an incredible idea. I'm going to take all of my notes and talk to whoever will listen to me down here.
Come visit us. Bring them up here.
That would be great.
Yeah.
But my question is actually about the tablets. How many of those do you have, and what did that take to get that started?
So the tablets have their pros and cons. The tablets are a wonderful resource. It keeps them busy. It's not an inexpensive tool, that's for darn sure. And unfortunately, they can manipulate them sometimes if they break the tablet and take that battery pack out of it. That's how they're using that to get that spark to ignite whatever it is that they may get into our facility. So they destroy the tablets as well. We do make them pay for that. If they have any commissary funds, we will take that money out of their commissary funds, and you also will have to go to SEG because you've destroyed governmental property. So that is a deterrent. We go through a company called GTL, ViaPath. It was quite an undertaking. Our facility can house up to 1,300, but we typically house 750. So sometimes we're breaking these tablets as fast as they're coming in. They'll come in 30 at a time, but they'll break 35. So we have a few inmates that might have to go without for a couple of days while you're here, and we wait for that next shipment to come in. GTL handles that completely. They have somebody on staff here that tends to that, but that's also how we have the inmate incoming mail come in. It comes in through there, so we don't have any incoming personal mail anymore, just legal mail. That's helped cut down on tainted papers and, contraband coming in. So, and then we approve through the tablet. Their outgoing messages get approved through the tablet. There's a fee for that. So that does help with some of the commissary funds going up, which is how we paid for the tablets through the commissary fund. I don't handle the tablets. If you need more information, reach out to me and I will get you in touch with our Major Egler.
That's amazing. Do you know if that's even happening anywhere else?
The tablets, yes.
Yes.
Yeah,
Okay.
that's becoming extremely transitional.
Okay.
Yeah, it has helped with psychologically, it has helped the inmates a lot. When you are in max and seg, you don't have access to your tablets. So I think it's a huge incentive to want to behave better, to do better so that you can be up in general population to have that.
Okay.
Yeah. So yeah, please feel free to reach out to me if you think you have any other questions that you want more detail on. I'll be happy to hook you up with Major on that one or get you the contact information directly through ViaPath.
Thank you.
Sure, no problem. Anything else from anybody?
Yeah, I would just like to echo what the other Jody had mentioned. It's very informative. You guys are doing wonderful work, and we tremendously appreciate you taking the time, putting this together, letting us have a, insight into what goes on in your jails and all the good work that you're doing. So we are
Well, that credit goes to our medical and mental health staff, and I have to give a shout out to Sana, both, I mean, not just her education, the fact that she speaks 5 languages and can communicate with many of our inmates because we're such a large facility, her kindness, her caring, her compassion. And the 1.5 years I've worked with her, I've never heard that's not in my job description. That's not what I'm supposed to do. It's always, what else do we have to do to make this bigger and better? What else do we have to do to help that person? Not the inmate, that person. So I'm very, very fortunate that this is who they've paired me up with to work with, because that's, not everybody has a sauna at their disposal either. So I'm very lucky there.
awesome. Well, it definitely shows. I mean, you can see in all the work that you're doing that you guys work well together and you have big hearts. So is there anybody else with comments or questions? Or I think I saw something that popped up in the chat. Just a thank you for sharing your work from Sharon. Thanks, Sharon.
And please feel free to reach out. Like I said, if you'd like to come for a visit, I'd love to show off the hard work that all our men and women on the other side of this wall continue to do for us. So yeah.
Awesome. And would it be possible to get a copy of the PowerPoint presentation that we could share with our members with the archive recording? Would that be possible?
No problem.
Okay, perfect. Well, thank you again. Thank you for your time and speaking with us. And thanks for those on the
Well,
Zoom.
thank you for
Thank
including
you.
us, and I'm very proud that the Winnebago County Community Mental Health Board thought of us to work with you. That says a lot about our commitment with them and their commitment towards us. So thanks to everybody all around.
Okay, I'll express that to them too. But thank you again. Have a great day,
Thank you.
everybody.
Thank you, Jody.
Thank you so much.
Okay,
Bye.
bye-bye.